and the date of admission was 28 June 2021. The patient presented with the chief complaints of breathlessness since 2 years, palpitations since 6 months, and cough since 1 month. History of presenting illness was the patient was apparently well.
One minute.
Yes, sir.
We would go step by step, okay? We would just keep dissecting, and we would also keep giving option for anybody to ask queries. So let's come back to your first one, where you said this young man presented with 27 years, presented with breathlessness for past 2 years, palpitation for past 6 months, and cough for a month.
Yes.
So anybody wants anything, any comments on that, or otherwise we'll take his comments. How do you react to this chief complaints? What do you make out of it?
Sir, I am to answer, or other people have to answer?
Aditi wants to answer that. That is okay. She has written something. Likely cardiology. So Bhavika Jutsi says likely cardiac etiology. Now, do you agree with this, Devavrat, that it is likely to be a cardiac etiology?
So till now, sir, it can be cardiac cause or respiratory cause. We will see it later in the future, in the history, and decide.
Because, you know, after Bhavika put it out, Kiranjot says respiratory system or cardiac system. So the one basic question comes based on complaints. How do you segregate cardiac from respiratory?
So shall I answer?
Yeah, please.
Or sir, other people have to answer?
No, others are answering on the chat. Unless your group wants to answer, that is okay, the 4 of you. But I can tell you that there are good answers coming on the chat, which I'll take up appropriately once you have given your comments.
Sir, it actually depends upon the history of breathlessness, and the type of breathlessness will be described further. And so usually in cardiac cases, the cough is a minor symptom, and in respiratory system cases, the cough will be presenting earlier and would be a major symptom. Whereas in cardiac cases, the breathlessness would be the major symptom, followed by cough after some time. So it is indicating towards a cardiac cause.
It indicates more like a cardiac cause. Any other thinking on that? So what respiratory problem can present with breathlessness and no cough?
Sir, interstitial pneumonia.
Okay, that's good. Interstitial pneumonias would present largely with breathlessness. And that actually is what happened in the COVID pandemic. The persons who became breathless became because of many reasons, not one. But for the lung, it was either an interstitial involvement that led to it, or the other is pulmonary embolism. They had this vascular thrombi. So pulmonary embolism also will cause it. You can take it as cardiac or vascular or pulmonary. Which cardiac cause will cause cough and no breathlessness? No palpitation. Kiran says LBF. So can you have LBF? Sometimes they call it cardiac asthma, where you have cough, and you don't know whether it is cough that is leading to breathlessness or breathlessness adding on to cough. So there would be overlap of all these symptoms. Irritative cough and cardiac asthma, Nisha has written. So you can have all these three things in cardiac or respiratory. Can they be there in any other disorder also apart from cardiac respiratory?
So breathlessness can be a presenting feature of sir, anemia or sir, any higher cardiac output state. So that will ultimately lead to through cardiac manifestations only.
Okay. And do remember that breathlessness is a little tricky to define in clinical medicine. Like last time we were discussing, a tachypnea, where in the previous case was occurring from metabolic acidosis, would also mimic breathlessness. It would be a deep and a rapid tachypnea, which could be misconstrued as breathlessness, and in emergencies and OPD sometimes it gets confused with actually breathlessness, which is from hypoxia. So you will have a condition where there is hypoxia with normal carbon dioxide causing breathlessness against a metabolic acidosis where the CO2 might go down low and oxygen may go up or be normal, and that can cause it. Palpitation is very unusual. Cough can come not only from the cardiac or respiratory, but can come from diaphragm, can come from upper respiratory tract, come from ear, can from other disorders. But what is relevant is not whether these symptoms can occur in A or B. What is relevant is this gentleman had breathlessness for 2 years. And then it progressed over 1.5 years to palpitation. And eventually it got into cough for only for a month. So the primary complaints, if you look at it sequentially, because it is the order of the history, it is the order of the history that will tell you what the disease could be, that will tell you what the details of the disease could be, and that also would throw light on what the etiology of the disease could be. So breathlessness starting of 2 years, progressing into palpitation would tend to suggest that it's a cardiac pathology and has complicated into cough, which could be out of the cardiac origin only, or it could have complicated from non-cardiac pathology also. Okay, please carry on.
History of presenting illness. The patient was apparently all right 2 years back when he started developing breathlessness on climbing 3 flights of stairs. It was exertional, insidious in onset, and has gradually progressed to breathlessness at rest since the past 1 week. Breathlessness increased on lying down since the past 10 days, which was relieved on upright position, associated with the nighttime awakenings. Also, there was associated use of accessory muscles for breathing, and no associated wheezing was present. He also experienced intermittent palpitations since 6 months and was insidious in onset, progressive, irregular in rhythm, and occurred on exertion and relieved on taking rest. It was associated with sweating, not felt during sleep. He also had repeated attacks.
One second, Devabrat.
Yes, sir.
क्या हो गया? आप उधर आईसी में रहना चाहिए ना, थोड़ा वेट करो, अभी मत करो. Okay, please carry on.
He also had repeated attacks of cough. He also had repeated attacks of cough over the past 1 month. Cough was associated with expectoration, which was non-foul smelling, pink, frothy, and about 5 to 10 milliliters in quantity. Increased on lying down position, no diurnal variation was present.
Okay. So, as we said last time, the presenting complaints refers to what the patient has got. And actually it has very big relevance because patient actually is interested in his presenting complaints to be tackled by the doctor. And history of presenting illness is something that throws light on what the diagnosis would be. So does it throw any light?
Yes, sir. The patient here is presenting with a typical history of PND, that is paroxysmal nocturnal dyspnea, that is followed up by orthopnea, and therefore we have classified the breathlessness based upon the New York Heart Association classification system, and which has progressed from grade 2 to grade 4. And yes, that's why, sir, it indicates morely towards cardiac pathology, because PND typically occurs in case of PND followed by orthopnea typically occurs in case of indicates towards cardiac pathology.
No, it does not necessarily indicate cardiac pathology, but it does occur from cardiac failure. So orthopnea PND would suggest a left ventricular failure where the left ventricular end-diastolic pressure would rise maybe to 20-25. But then tell me something. You said he progressed in NYHA classification. What do you mean by that?
Sir, grading of breathlessness has been done based upon the New York Heart Association, and it is graded into 4 categories: grade 1, 2, and 3, 4. Sir, basically the heart disease patients are graded according to this scale, in which a patient with heart disease and no limitation of activity, physical activity, was graded as grade 1. And a patient of heart disease having slight limitation of physical activity with ordinary activities that causes symptoms is graded as grade 2. And a patient with marked limitation of activity, difficulty in doing less than ordinary activities is graded as grade 3. And the patient cardiac patient who is symptomatic at rest will be graded as grade 4.
Okay, so let's invite comment on that. Does everybody agree with this, or somebody has got a differing opinion? So while they're coming back with their responses, there are 2 responses, very valid responses that have come out. One is,
Yes,
Meher is saying, can there be palpitation in any respiratory disease?
Yes, sir. There can be.
You are sounding a little doubtful, not confident.
Yes, sir. Actually, sir, whenever there is increased resistance in the side of lung, there will be more effort from the side of the heart, leading to overcome the pressure. So, sir, there can be, as in this case, sir, the pulmonary hypertension can lead to right ventricular hypertrophy or something like that, or in case of dilated cardiac myopathy also, increase in surface area can induce arrhythmogenic conditions and can lead to palpitations also.
So that means you can get palpitation when there is not oxygen demand is not being met and cardiac stroke volume goes up. The second is the rate goes up.
Yes.
And the arrhythmia, the rate going up, multifocal atrial tachycardia is so well known in chronic respiratory diseases that it is characterized with chronic respiratory diseases. So you can get arrhythmia, you can get hypoxia, you can get high ventilation, and Dipender says pulmonary arterial hypertension could also be into this. So while we are on this, there is probably overlooked, Arushi and Dipender have put out. Could this be all anemia? After all, one gets presenting complaints of breathlessness from not being able to meet the oxygen demand, which would be heart is not circulating enough hemoglobinized blood, or respiratory system is not oxygenating the hemoglobin, or maybe there is no hemoglobin. So could it all be anemia?
Yes, sir, it can be anemia. It can be one of our differential.
So remember, when there is breathlessness, we always tend to overlook, especially in males. In women, we would never overlook. We would think it could be anemia. But in men, young men, we tend to overlook that anemia would present the same way like a cardiac illness. After all, the manifestation of anemia and that of cardiac illness, they all overlap. The convergence is there, and that is not being able to meet the oxygen demand. That's a very, very good question. So I still did not hear any comments on NYHA. Now, Devvrat, NYHA does not grade. The grading of breathlessness is done for some pulmonary diseases separately, but New York Heart Association categorizes them and calls them class 1 symptomatic, class 2 symptomatic, class 3 symptomatic, and class 4 symptomatic. And it takes into consideration not only breathlessness but other parameters also. But as you rightly said, class 4 will be something who is symptomatic at rest. Class 3 will be something less than usual activity will be 2, and exertional will be 1. So this gentleman progressed from usual activity to getting symptomatic, class 4 symptomatic at rest. Is that right?
Yes, sir.
And this happened over a period of 2 years, or it happened only during shorter duration of the 2 years?
Sir, he progressed from grade 2 to grade 4 in the past 2 years and remained as grade 1 in the past 1 week.
So, which of the cardiac illnesses, if you're thinking of, will progress like this, that from class 2 symptomatic, they'll become class 4 in 2 years?
Sir, it can be a case of valvular heart disease or mostly, sir, left-sided valvular heart disease.
It could be valvular heart disease, which you see in the young adults. It can be a myocardial disease, which is in young adults or the elderly. And it can also be congenital heart disease. And different diseases have got a different natural history. Now, just before anywhere, Dipendra has put out that NYHA looks into their classification not only at breathlessness but other parameters also, like fatigue, chest pain, and palpitation. And Keshav wants to know, can you get orthopnea and PND in anemia?
Sir, the basic So the basic reason of orthopnea and PND is that, sir, I don't know the answer, but sir, the basic pathology behind PND is because of at night, due to increased venous return from the peripheries and due to the REM sleep, increased heart rate, there is excessive pressure on the heart to pump the blood. So, sir, therefore, congestive symptoms develop and patient wakes up with sweating, apprehension that something unusual is happening. These all lead to the PND. So, sir, in case of anemia, these can be there, but sir, I'm not sure.
Okay. So anemia can cause these symptoms for two reasons. One is the oxygen demand is not being met. So you get this stimulation of the peripheral receptors. But remember, anemia also leads to left ventricular failure as such. So if there is a left ventricular failure of whatever origin, that could lead to orthopnea and PND, and this could also occur in severe anemia. Could hyperthyroidism be the cause? There is palpitation, breathlessness, and some cough from the thyroid which is pressing on the trachea, let's say. Harshita Chaudhary has raised this possibility.
So, but sir, hyperthyroidism can be the cause, but it will not be due to the pressure symptom. Because sir, if there is a pressure, it will continue to impinge the pressure even after waking after PND. But in case of PND, the patient wakes up, normalizes within 30 minutes if the PND is due to cardiac origin, and then sleeps. But in case of if there is a compressive symptom due to which it is occurring, then it can be a differential of PND, but it cannot be PND.
No, Harshita didn't write like that. I meant was if there is compression symptom, that would explain the cough. Palpitation would occur because of hyperthyroidism. Yeah. So it was not because of palpitation and breathlessness occurring from compression. No, no. Compression was brought in only as a operation. But could it be hyperthyroidism?
Yes, sir, it can be, but sir, it wouldn't be exactly exaggerated at the night time. And sir, it can be, sir. I'm not sure.
Breathlessness because of a thyrotoxic cardiac involvement. Huh? Why breathlessness in hyperthyroidism?
Sir, increased heart rate leading to increased workload upon the heart.
So there is an entity called cardiac involvement in hyperthyroidism, thyrotoxic cardiac disease. Now remember, we should not confuse two things. When we are making a diagnosis in clinical cases, in wards, in OPDs, we make what is called clinical diagnosis. We call it cardiac involvement. Okay. Now the cardiac involvement, the etiology could be, as I said, commonly valvular diseases or the elderly degenerative diseases or congenital diseases, or sometimes the endocrine diseases, including this. So don't confuse the two. Hyperthyroid can cause it, and there is no way you would be able to make it out. But then we have to work backwards, rather forwards, not backwards. Forwards in the sense that you take the cause of breathlessness forward. Cardiac, respiratory, or hematological anemia. And once it is cardiac, then you come to the etiology as a second phase, whether it is thyrotoxic or it is, something else. So I think hyperthyroidism does not primarily come into this, may come in secondarily as a part of secondary diagnosis or the etiology, primary etiology of the cardiac failure. Somebody wants to support you, Ishika wants to support you, pink frothy sputum can't be thyroid. No, as I said, thyrotoxic cardiac disease is a separate entity. Hyperthyroidism can also lead to heart failure, and Arun has rightly pointed out, anemia, thyrotoxic, high cardiac failure, and cardiac symptoms. Such a good statement, Dipender Singh. Now, this also throws to you the option that when there is anemia or thyrotoxicosis and you're going to do the examination, you would be looking for signs of high output cardiac failure. Okay? And tachycardia in hyperthyroidism can be confused with dyspnea, not sure, but just a thought. Yes, of course. Yes, of course. But remember that hyperthyroid patients usually are so energetic, they don't complain of weakness as such. But once they progress over a period of 2 years or 6 months or 1 year, then their muscles give away and they start feeling weak, even though they are full of energy. In thyroid disease, why should there be cough? Jyotsna Madan wants to know. Of course, thyroid is there. If it starts pressing on the trachea or the cricoid, then that can cause some kind of cough, also irritative cough. High output cardiac failure, Chavi Harkavat has raised this issue. Okay, so we would come out that based on what you are presenting, he has a progressive breathlessness for 2 years in a young 27-year young man who has been hale and hearty previously, no previous illness, and it is associated with PND and orthopnea, so rapid progress. And this kind of a rapid progress could occur in valvular diseases like aortic valve diseases. The mitral valve diseases are slow rising, they take time. And the aortic valve, once they come down, they go like that. And he is actually young for degenerative or a cardiac diseases of the ischemic kind, but cardiomyopathies secondary to myocarditis can occur anywhere. So young man has no previous congenital heart disease, nothing to suggest a rheumatic heart disease. If there is myocarditis, that could linger on and evolve into cardiomyopathy. That is another one option. Okay, please carry on.
There is there's no history of chest pain, no history of syncopal attacks, no history of cyanosis or bluish discoloration of the face or oral cavity, no history of fever, hemopsis, infection, not infection, wheezing or sputum, pus associated with the cough. No history of sir, no history. This is history of associated tiredness or fatigue. Um, that's it. That's it. Or previous cardiac surgery. There is a history of migratory joint pain involving the large joints, knees and wrists at around 11 years of age, for which the medication aspirin was taken, specifically was mentioned by the patient. No history of involuntary movements. Associated history of fever or skin lesion cannot be recollected by the patient. No history of skin rashes, nodules, small joint or any deformity. No history of drug abuse or previous cardiac surgery.
So good. So now you are giving us some lead from the history suggesting that it may have been a history of rheumatic fever earlier. Remember, for diagnosis of rheumatic fever, we have the modified Jones criteria, which we don't meet all the time in clinical medicine. But even if there is a history like this, you may not be able to get all the details. You would assume that at 11 years, the person could have had post-streptococcal rheumatic fever. And it takes a couple of decades after the rheumatic fever for the valves to get involved in. So
yes,
basically involvement is two valves are more commonly involved, the mitral valve and the aortic valve.
Aortic.
Is history different in the two?
Yes, sir. In case of aortic valve disease, the disease progresses quite rapidly. But in case of the mitral valve disease, the disease is slowly progressive. It first leads to the increase in pressure in the left atrium. That is that causes the first symptom of palpitations and dyspnea due to the congestion. Palpitations can occur due to that, and if it is significantly enlarged, so for example, sir, left atrium chamber is around 4 centimeters. So if it enlarges to just 4.1, it can lead to palpitations. It can lead to arrhythmogenic foci production and can lead to palpitations. And if we go further on the natural disease of the natural history of the disease, initially there is valvitis, due to which there will be mitral stenotic kind of presentation, and then the pressure will be transferred upon to the pulmonary veins, and there can be an episode of so this is always progressing in for a very long period of time. It takes about 10 years to reach to the stage of pulmonary hypertension and things like that. And sir, do you want me to explain the pathology, or I actually lost the question?
No, the question was simple. You were going on it that the mitral valve disease natural history versus aortic valve disease rheumatic natural history. Are they different? And can you make a guess on what this history is suggesting?
Yes, sir. This is probably suggesting the mitral valve disease because it is a quite long history from the period of the attack of acute rheumatic fever, and now he is presenting with rheumatic heart disease, and most probably presenting with rheumatic heart disease. Yes, sir.
Yeah. So Chetan says mitral valve disease, palpitation, PND, exertional dyspnea, and failure. That is the sequence.
Yes, sir.
You think so?
Yes, sir. Broadly, sir, this can be the sequence, sir.
Okay. Anisha says aortic valve pathology has more of syncope, angina, and dyspnea, which is true. I mean, it
Yes.
is sad. You should remember this sad acronym for aortic valve disease: syncope, angina, dyspnea, and death. Also, sudden. So this looks more like mitral valve disease. So when there is a mitral valve disease, there is a increased pressure in the left atrium, and when the blood does not get into the left ventricle because of the valve, it creates a differential pressure, and the differential pressure is proportional to the square of the velocity of the blood, from the left atrium to the left ventricle, the Bernoulli's principle. So as it goes, it is 4V square. So the differential becomes so high that the left atrium can cause pulmonary edema, the kind of symptoms that this person developed, and all this comes in. Where does the cough fit into this?
Sir, initially once there is pulmonary edema, the fluid will come out of the pulmonary vessels and pressure in the atria. Sir, in between there are symptoms of so-called winter bronchitis that can lead to cough-like symptoms and hemoptysis also, and sometimes when the pulmonary veins disrupt. And sir, in case it occurs, sir, you're not audible. Excuse me, sir. Sir, you're not audible, sir. Yes, sir. Now you're audible.
Yeah, no, it'll be audible. Yeah. So there was something was. So one thing is there. I was asking, where does the cough fit in? You said, so this concept of the fluid seeping out of the alveoli. One second. Hello. Yeah. तो मैं कह हाँ इनका नाम है मिस्टर अशोक राणा, इनकी 52 है, ठीक है, हाँ ठीक है, ठीक है, ओके, थैंक यू। One second ना, अरे अशोक ऐसा करना, यहाँ कॉलेज के पीछे निकल रहा ना, सीएजी का ऑफिस बना है, बाल भवन है ना, बाल भवन के आगे जाके सीएजी सेंट्रल ऑडिट वालों का, उसमें डॉक्टर विशाल हैं, उनसे मेरी बात हो गई है, वहाँ चले जाओ, आपका सेकंड डोज लग जाएगा। ओके, दिक्कत हो तो बता। ठीक है, ओके। या प्लीज, नो नॉट यू, आप चलो, मैं इधर हमारा मीटिंग चल रहा है। हेलो, या
यस सर।
So I was saying, where do you think the cough fits in?
Sir, in case of pulmonary venous and pulmonary capillary hypertension, or sir increased pressure, it can lead to the capillary rupture, and it can be followed by pink frothy sputum.
Yeah, I was commenting on that. So I think the simplistic explanation that has been given for ages is that when there is pulmonary edema, which basically comes from the increased vascular pressure, it tends to give an impression that the fluid comes out and that causes pulmonary edema, which causes bubbling. It does not happen actually like that. But the cough, there could be other reasons for mitral valve disease, but because it compresses on some part of the bronchus also.
Yes, sir. The left atrial enlargement will compress on that.
Could compress on the bronchus and give rise to a left lower lobe collapse or infection.
Yes, sir.
And sometimes was the recurrent laryngeal nerve. So the cough in a case of a mitral valve disease coming later, two years later, makes greater sense with mitral valve disease. And mitral valve disease also, because of the left atrial appendage getting enlarged, as you said rightly, could lead to arrhythmias, atrial fibrillation, and the palpitation that this person has. So the history would fit in very well with this migratory pain and other things fitting. Okay. So
Yes.
now let me read out some comments before we go further. Aortic pathology, ARF, true aortic pathology occurs later than mitral valve pathology. Right, very right, Anisha. And aortic valve disease will come with history of syncope and chest pain. No, that is that this is very this one must keep in mind. Aortic valve disease patients may not have any symptoms. So when we say syncope, angina, dyspnea, or whatever, if those manifestations are there, it helps towards thinking of aortic valve disease. But their absence does not rule out aortic valve disease. Then Keshav says syncope and angina attacks are not present. Can it help us go towards mitral valve disease? No. The absence does not help, the presence helps. Stenosed valve, left atrial dilatation, back pressure in pulmonary veins, pulmonary edema called winter bronchitis, temporary phenomena coming out from Chetan Kumar. Okay, Devvrat, I think we can proceed further.
Yes, sir.
Yeah.
Slide. There's no history of hoarseness of voice, no history of dysphagia, no history of edema of feet, abdominal distension, pain in the right hypochondrium, anorexia, and nausea or vomiting. No history of petechial hemorrhages, painful fingertips or nodules on the fingertips. No history of embolic episodes such as hematuria, limb claudication, acute chest pain, and hemiparesis.
Okay.
Yes, sir.
So where are we?
The patient was
examination. Are we any wiser? Yeah. Please carry on.
The patient was taken to the hospital 5 months ago for breathlessness, where he was told that he has a heart disease for which oral medication furosemide was given. There was symptomatic improvement initially, but later on it progressed to the current state. Regarding the previous treatment, there is history of monthly injection given to the patient after the episode of migratory joint pain, which was discontinued by the patient himself as he experienced no symptoms. No history of any other current ongoing medications are there.
Okay.
No history of hypertension, past history, no history of hypertension, diabetes, asthma, no history of previous surgeries, no history of weight loss, low-grade fever, night sweats, or hemopsis.
Okay.
There is no history of breathlessness or any known cardiac disease in the family, no history of cardiac-related deaths in family. The diet of the patient is mixed. The calorie intake is, as mentioned, appetite is decreased, weight slightly increased, and sleep was disturbed initially due to the episodes of breathlessness, but was relieved as the patient started sleeping in semi-erect position. Bowel and micturition habits are normal. No history of smoking, alcohol, or any other drug abuse.
Okay.
The socioeconomic history here can be important because we are suspecting the rheumatic cause, and the patient lives in a pakka house with 4 members in the family, 1 room and 1 window present. Income is 7,000 rupees per month. Modified BG Prasad scale. The patient belongs to the social class 2.
Okay.
So the summary of the patient till now is he's a 27-year-old patient named Mr. XYZ and presented with grade 4 dyspnea associated with orthopnea and PND, intermittent irregular palpitations on exertion, cough with pink frothy expectorations, and a past history of migratory joint pain is present. Based on the history, it is most likely to be left-sided cardiac failure that is causing the pulmonary edema with that is exacerbated due to atrial fibrillation. And differential diagnosis can be mitral stenosis with atrial fibrillation and mitral stenosis with chronic MR or chronic MR or aortic fibrillation.
Mitral stenosis with atrial fibrillation, mitral stenosis with chronic MR. Chronic MR. So why do you put MR against mitral stenosis?
Sir, sir, it is a differential only after such a long history. There can be MR, sir. It's not. I cannot justify it that good.
So is the history different in mitral stenosis versus mitral regurgitation?
Sorry, sir.
Is the history different in mitral stenosis versus mitral regurgitation?
Yes,
You're
sir.
concentrating on history. So I think whether you can call it mitral valve disease, what you should think is differential diagnosis. I think it is rheumatic heart disease, mitral valve disease, more likely to be mitral stenosis because that is what we see more commonly. And there is nothing to suggest aortic regurgitation as such, but the predominant reason is mitral valve. Okay.
Yes.
But tell me, just for the sake of discussion, you
Yes,
said
sir.
there is no history of hypertension.
Yes, sir.
How do you make that statement? It's very
Sir,
difficult to make that statement because majority of the persons with hypertension have no symptoms. Okay,
okay. Yes, sir.
so 80% do not have symptoms, and once they don't have symptoms, the history of hypertension can only come in if he has got his BP measured. So you could, there are two ways of doing it. You could say that there is no history of hypertension, but then he never has got his BP measured, which
Okay.
means you're leaving. That tends to bring out that Debabrata is a brighter student. He thinks of everything. Hypertension, if 80% don't have symptoms, why? I mean, primary hypertension, then why should we be worried about it? And if we think of secondary, then there are many other things that are going with it. The second thing is, somebody was raising a possibility of hypothyroidism in the beginning. Now you said the weight is increased.
Yes, sir.
What do we do? Do we go to hypothyroids?
Sir, it can be due to the edema, due to congestion. The weight slightly increases in this case.
Very, very true. So it is more likely to be the edema. And remember, the edema is going to be seen. It is going to be seen as weight gain. Okay.
Yes.
So let me just put a couple more questions because I think I've lost it. ARF, MR, no, syncope and anginal attacks are not present. MR has more of a fatigue initially. I missed something somewhere. I don't know where it was. As patient is young and examination has not been done, why dilated CMP is not a diagnosis? Keshav Garg is asking me.
Yes, sir. Dilated CMP can also be one of the diagnoses, sir. In the next slide, I think we have kept it.
Yeah, but you see, cardiomyopathy. Actually, I think I consider it more like a dustbin diagnosis. Dustbin diagnosis in the sense that there are many etiologies for it. So it's not a primary diagnosis. And it could be myocarditis, as you were saying. Of course, it can be that. It can be that. But if you look into the history of 2 years with something suggestive of rheumatic fever, the possibility of cardiomyopathy can be kept in differential diagnosis, as Keshav is suggesting. But then you say there are points in favor, positive points in favor of rheumatic rather than cardiomyopathy. And the cardiomyopathy, as I said, there are many, but in a young man, you will think of myocarditis followed by cardiomyopathy. It will be like one myocarditis and then this progressive illness, which it is not showing. Now, I think there was some question that came up on, sir, your voice is not clear. Is my voice clear or should I switch off the AC?
Sir, it is clear, sir. So now it is clear. In between, it was bit muffled, and now it is clear.
I have switched it off, no problem. So then there was something coming on the diagnosis also. I don't know what was a diagnosis. So when somebody wrote his cardiac failure a diagnosis or something like that. I'm not able to pick that up. So let me tell you, when it comes to making a diagnosis, and I repeat it time and again with every batch, as a good doctor, your primary responsibility when you're managing a patient is to come at a diagnosis. Because once you have a diagnosis, you can decide on the treatment. Anybody can decide on the treatment. Once you have a diagnosis, you can decide on management, investigations. Once you have a diagnosis, you can talk about prognosis. So diagnosis is very, very important. But then what we tend to forget is diagnosis is a very big domain. So whatever you read it through in MBBS, you put it into diagnosis: anatomical diagnosis, physiological diagnosis, biochemical diagnosis, microbiological diagnosis, pathological diagnosis. And when we said physiology, we basically mean functional. So let's say if somebody has got a pneumonia, you must be able to make out and convey to the examiner or to yourself, more important than that, that it's a pneumonia involving which anatomical areas. So if it's a small segment pneumonia which is getting involved, it may need only outpatient treatment, nothing more. So whereas if it is huge pneumonia, it might need a ICU care. So anatomical involvement, physiological is functional. This pneumonia could be associated with respiratory failure. So pneumonia with respiratory failure, left lower lobe pneumonia with respiratory failure, or bilateral lower lobe pneumonia, or a small upper apical segment pneumonia with no respiratory failure. So functional is very important. Microbial diagnosis, tuberculosis, Klebsiella, strep, pneumonia. So that will decide, or viral pneumonia or COVID pneumonia would decide what is to be done. So anatomical, physiological, microbiological, functional, all of them are important to decide whether the patient is hospitalization, ICU, home treatment, or whatever. So when you make these diagnoses, and that is what we probably did not stress enough. When you make the diagnosis of a cardiac disease, there is no diagnosis, as you say, but then this is part of the diagnosis, because once you say cardiac, then you say failure. Failure is no diagnosis. Failure is a manifestation. But then that helps you come to the diagnosis. So these are all linked. So history, symptoms, sometimes you put them into a syndrome, nephrotic syndrome, no diagnosis. Fever, no diagnosis. Malaria is a diagnosis, but then malaria can come without fever also. So to lead to that chain, you might hang on to some symptoms or signs or clinical syndromes, and then arrive at a diagnosis, which could be a clinical diagnosis followed by a pathological, microbiological, biochemical, physiological, anatomical diagnosis. So something was there I forgot, but then that is what we should keep in mind. Now, there is a question that has come: dilated cardiomyopathy, primary cause IHD, ischemic heart disease, followed by alcohol intake, and in this case, there is no history of that. Chetan Kumar is asking, how do you react to this?
Yes, sir, he's supporting me.
Sorry?
Yes, sir, that's why I've kept dilated cardiomyopathy at the end. In the next slide, you can see I've kept dilated cardiomyopathy in the next slide.
So I think one of the things we have to come back again is dilated cardiomyopathy is a clinical diagnosis. You can call it more like a clinical diagnosis. The etiological diagnosis is part of the larger diagnostic framework. Etiological diagnosis could be ischemic heart disease, which we are likely to consider if a person is elderly. But then we see ischemic heart disease in 20s these days. In fact, we see in teens also. Alcohol intake, yes, of course. But then these two alone are not the causes of dilated cardiomyopathy. I was mentioning in between, if you have a young man and you come across a dilated cardiomyopathy, the chances are he might have had some viral myocarditis followed by dilated cardiomyopathy. So we are not going to think of ischemic heart disease or alcohol or amyloid in those, but it can still be there. Okay, and you have put it out. And why have you put out infective endocarditis as one of the diagnoses?
Sir, it is just a probable diagnosis, nothing else, sir. Not much.
No, infective endocarditis, remember we spoke last time, infective endocarditis is a medical emergency. And infective endocarditis, one of the very favorite question is, what are the clinical manifestations of infective endocarditis? Or one could ask, what are the clinical symptoms or clinical signs or clinical manifestations of infective endocarditis? Can you think of any that are present in this case?
No, sir. I have also gave the negative history of painless nodes on the fingertips also, and no, and also there was no embolic history.
No, negative history will not help. Infective endocarditis, you should have at least, you should have a fever or a sudden worsening or hematuria or other nodes and whatever you are there. And Ishika also is saying, sir, won't fever be a must for infective endocarditis? Yes, fever is likely to be there. Yes. Okay, so let us move further. So you have come to a very good differential in this young man who presented with progressive breathlessness over past 2 years and palpitation and developed cough for 1 month. You also elicited a history which was suggestive of rheumatic fever, actually arthritis, polyarthritis, migratory arthritis, which tends to favor a diagnosis of rheumatic heart disease. And this kind of a history would fit into mitral valve disease. And that could also explain the cough that he developed for the past 1 month. Good history. Let us go to the examination.
So examination will be presented by Chetan, sir. Thank you, sir.
Okay. Yes. Chetan has been supporting you. I must say, Devabrat, he has been writing, I am supporting Keshav's doubt. Not you, but Keshav is supporting Keshav, who was asking about cardiomyopathy. Okay. Yes, please carry on, Chetan.
Good morning, sir. I'll be presenting the examination part. General physical examination. The patient was examined with due consent in a well-lit room and was well oriented to time, place, and person. Examination was done in a semi-erect position. The patient is averagely built, weight 60 kgs, height 171 centimeter, BMI of 20.7. He is afebrile. Pulse was 106 beats per minute, irregular in rhythm, normal force, adequate volume, equal on both sides, taken in the right radial artery in sitting position, no radio-radial delay or radiofemoral delay. Peripheral pulses are well felt. Respiratory rate was 18 beats per minute and it was abdominothoracic. JVP was not raised. Sir, in these slides, we can see the pulse is high with irregular rhythm, which most likely indicates towards mitral stenosis. And also, sir, we have normal pulse pressure as we have seen in next slide. The blood pressure is normal, and pulse pressure, that is 118 minus 76 is 42, which lies in normal range. So we have normal pulse pressure with irregular uh, rhythm pulse, which indicate uh, our diagnosis towards mitral stenosis. Hello.
Yes, I am hearing you.
Okay, sir, thank no signs of pallor icterus, clubbing, cyanosis, edema or lymphadenopathy. No signs or markers of infective endocarditis, that is petechiae, osseous node, Janvey lesions. No signs of atherosclerosis. no stigmata of tuberculosis or syphilis. Cardiovascular examination on inspection, the size and shape of.
No. 1 second, Chetan, don't rush. Come back to your first slide. So you said you examined the patient in semi-erect position. What does that mean?
Sir,
Hello?
hello.
Yeah. What is, you said you examined the patient in semi-erect position.
Sir, semi-erect position is, sir,
I really don't know. I mean, I just want to know what you're meaning by that.
sir, it means incompletely upright posture. Sir, patient was comfortable
It's
at
very
sitting
sick. I don't know
position.
what you mean by that. Sitting position is okay. That is understandable. But I don't know this term. Anyway. So what you found was 106, you should simply recognize this as it is suggestive of tachycardia. Okay? But then this tachycardia was not sinus tachycardia, it was irregular rhythm. Okay?
Yes, sir.
When you say it is irregular rhythm, you must qualify whether it is regularly irregular or it is irregularly irregular. That's very important. So if there is a 2:1 rhythm, then there could be the pulse is generating at 212 and every alternate is dropping, so it comes to 106. Whereas irregularly irregular would be no two beats have the same time interval in between. And if fast, irregularly irregular pulse under these circumstances would tend to suggest not MS, it would tend to suggest atrial fibrillation. And one of the common causes for atrial fibrillation is MS. So that will be indirectly pointing to MS, not directly pointing to MS. Equal on both sides. I don't know how will you make out equal on both sides. Remember, when you are doing a pulse examination and it is irregularly irregular, to compare the two would become very difficult. Taken in the right radial artery in sitting position, no radial delay, very difficult to make out, and radiofemoral is even more difficult to make out. Peripheral pulses are well felt. Now, respiratory rate is 18 per minute. What is your comment on that? What is your comment on respiratory rate of 18 per minute? Is it normal or is it abnormal?
Sir, it's a normal respiratory rate.
So, okay, you think it is normal respiratory rate and Jvp is not raised. That makes it unlikely that person should be a person who is orthopneic and PND would have a normal respiratory rate and a normal Jvp. Okay. So for this tachycardia, fast, irregular pulse, what else do you look for? Anisha
Sorry,
wants
sir?
to know what is pulse deficit? What is pulse deficit? So pulse deficit is you can feel the pulse at the apex or you can auscultate and then you see whether there is a equivalence between the what you see the auscultation at the heart and the what you feel at the radial pulse. Okay, so there is no JVP elevation, no tachypnea. that must be taken, as either he has been receiving very good treatment, that's why he became all right, or there was something wrong with our assessment. How do you look for JVP? How do you look for JVP? This came last time also. Okay, so why are you unable to speak? Hello? Why are you unable to speak? Chetan says, I'm unable to speak. So, okay, so you look for the pulse deficit. You also look for the general condition of the patient, where the patient feels and says he's breathless. If he has been treated and become all right, then maybe he's not breathless. But if he's breathless, he shouldn't be having a normal JVP and a normal respiratory rate. So, can't unmute myself. Oh, so will somebody unmute Chetan? Okay, that way. Chetan says, will somebody unmute me? Where is Chetan? Okay, let us see. Chetan. Chetan Kumar is not there. Why mute? He's just not there. He is trying to log in again, I believe. Yes. Chetan was trying to relog. Okay, so Devabrat or somebody else can come in while he is trying to log in. So there is
Yes,
somebody
sir.
else also who is, yeah. I think Chetan is
Sir,
having some problem logging.
yes, sir. So he was the organizer, and somehow he had the problem. So
That is okay. These things are, they can occur with anyone. And if they occur with organizer, that makes it more difficult. Nevertheless, let us go back to where we were. And remember that JVP, as we said last time also, there is a lot of confusion about how JVP should be measured. So if
yes, sir.
this is the vein, I don't have a test tube, but let us say I have a test tube, or this were filled with a colored ink up to this height. Now, once I put it vertically up against the gravity, this would be called the hydrostatic pressure. Okay? And if I tilt it, then the top level would start moving up, and once it comes nearly flat, everything will come out. So that means if in an upright position the hydrostatic pressure was 10 centimeters, as I decrease the angle, it starts becoming 11, 12, 13, 14, 18. So how do we make out? Because Devabrat could examine at 30 degrees and he'll find it is 18 centimeters. Chetan does it at 90 degrees and he finds it at 10. There will be a confusion in the mind and the documents as to whether the pressure was 8 centimeters or 18 centimeters. Remember, the vein is like that, the jugular, internal jugular. So the idea is whatever pressure you measure, in whatever position you measure, it should be the same. And that
Yes.
is where the physics comes in. If you do like at 30 degrees and it is 18, and you draw a perpendicular, and you will see that the perpendicular height, the vertical hydrostatic pressure would still be 10. So when you measure the JVP, you can do it 90 degrees or you can do it 10 degrees. There is no restriction. If you find that it is at, so why we do it 45? Why do the books write about 45? So the reason why books write about 45 is if you put the person in an upright position and you want to measure the JVP, you will not be able to see the JVP because the JVP is hidden behind the clavicle. It has gone sub-intraclavicular also, maybe behind. So you cannot see it in a normal person. In a person who is abnormal, like the case we had last time, the JVP was visible even in sitting position, and that means you could just measure the hydrostatic pressure. And that actually is so good. I mean, if you find it here and you measure the hydrostatic pressure from that upper point of the JVP to the manubrium sterni, 8 centimeters, and add 5 centimeters, which is the center of the right atrium from the manubrium sterni, you could just simply judge 13 centimeters is the pressure of in the right atrium. So that is vertically, you can do it very simply if it is visible. But the chances are a healthy person, it will not be there. In a person with elevated JVP, it may be there. But healthy person, you may not see it. Most of them are likely to be healthy when you examine. If you take it to 10 degrees, then the pressure, normal pressure, would fillet almost the whole of it. And you will not be able to make anything out because the rest has gone intracranial. You can't see the upper level. Unless you the fluctuating upper level, you'll not be able to figure out where the JVP is. So just like in vertical position, most of the patients will miss out unless there is a very high elevation. Similarly, you'll miss at 30 degrees. So that is why 45 degrees is taken as an indicative angle. It need not be 45, it can be 40, it can be 30. But that is where you are likely to see the pressure somewhere. And once you see the pulsating waves, then you see the vertical height with the two scales and add it to the, take it up to the manubrium sterni and add to the center of right atrium to get into the pressure. And remember, jugular venous pressure is as important when it's elevated, as I said, in vertical position. If it is 10 like that, and you know it is 10 above this, it can also be low. So jugular venous pressure has got 3 categories: high, low, or normal. So when you say jugular pressure, venous pressure is not elevated, that is actually not sufficient. You must say either it is normal or it is abnormal. If it is abnormal, it is high or it is low. Okay. So, and he said no pallor, clubbing, cyanosis, edema, lymphadenopathy, no edema also. This is very strange. There was so much of failure, no right-sided failure, no signs of markers of infective endocarditis, no signs of atherosclerosis. Remember, xanthomas and xanthelasmas are not actually markers of atherosclerosis. If you want to see the atherosclerosis, you should palpate the arterial pulse wall. No stigma of TB or syphilis. Okay, so that is the examination. Now is Chetan back? Chetan, are you back?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Okay. So we have gone, we were going through the slide that you projected last. Let us move further. Now, once again, at who is this? You have said it, is it? No, Chavi says at 45 degrees, 2 perpendicular ruler, 1 at sternal angle, the highest point measure plus 5 centimeter, give rise to the right atrial pressure, not JVP, right atrial pressure, or you can call it JVP also. Okay, fine, go ahead. Please move on.
Cardiovascular examination on inspection. The size and shape of chest is normal.
Yes.
Trachea appears in midline. There is slight bulge of the precordium. Apex impulse is seen near left fifth intercostal space, lateral to the midclavicular line. Left parasternal heave is visible. Epigastric pulsation and left second intercostal space pulsation are visible. No dilated veins, sinuses, or scars over chest.
Yes. Yes, please carry on.
On palpation, trachea is in midline. Apex beat is felt in the left fifth intercostal space, 1 centimeter lateral to the midclavicular line. It has a tapping character that is short and snappy. S1 heart sound is palpable. P2, that is diastolic shock, palpable. Left parasternal heave is present. Diastolic thrill palpable over apical area. no other palpable sound or rub. Carotid artery pulsations are normal, no thrill.
Okay.
On percussion is not done as it would provide any extra information.
Okay.
On auscultation, in the mitral area, there is a loud S1 heart sound, an opening snap followed by a low-pitched rumbling mid-diastolic murmur, which is better heard in the left lateral position and with the bell of stethoscope. Grade 4 murmur, the intensity of murmur increases with squatting, exercise, expiration, and decreases on standing or inspiration. S3 and S4 sounds are not heard. In the pulmonary area, P2 is loud, no significant sounds or murmurs heard in other areas. S2 split is normal. Other systemic examination, on elementary examination, liver and spleen not palpable, no hypochondrium tenderness, no ascites. In respiratory system, fine inspiratory crackles heard limited to the base of lung on auscultation. On CNX examination, the patient was conscious and well oriented to time, place, and person. So, according to history and examination, patient 27-year-old male presented with progressive dyspnea associated with orthopnea and PND, exertional intermittent irregular palpitation, and pink frothy cough. On examination, JVP was slightly elevated, epigastric and second intercostal space pulsation visible, S1 and P2 heart sounds palpable, tapping apex beat shifted outwards, diastolic thrill palpable, parasternal heaving, mid diastolic murmur, opening snap, loud S1 and P2 sound, P2 heart sound noted. The findings are suggestive of acquired valvular heart disease, most probably mitral stenosis.
So, Chetan, first things first, you said JVP is slightly elevated. Now, and previously you wrote JVP not elevated. And we were discussing that a person who is breathless or orthopnic, by definition, by very its nature, should have tachypnea and maybe
Yes,
elevation of JVP also. Yeah.
yes,
So,
yes, sir, yes,
what
sir.
do you mean by slightly elevated? You know, slightly elevated is a very difficult term.
Mm,
So it
I
will
don't.
become very clear once you measure it. And in clinical medicine, the clinical medicine is not as precise as laboratory medicine, which also has its own weaknesses. It is also not highly precise. Clinical medicine not being very precise, if you are in doubt about any sign, slightly elevated, that means it has no significance, no relevance. And I don't think you should confuse by saying it is elevated. It is possible that it was elevated and I could not pick it up. But if I could not pick it up, I should say I do not find the JVP elevated. Or I could be more precise that I can see the upper level of JVP and I don't find it elevated. Remember when you were coming in, I also said JVP could be elevated to the 90 degrees upright sitting position. And I also said that JVP, if you measure it at a lower angle, 10-20 degrees, it will not be elevated because it will be filling up. But there the relevance is it may be low. And actually, Harshita wanted to know which conditions would you get a low JVP. Very good question. One hand we get congestive cardiac failure patients, other hand we get patients where this effective circulating arterial blood volume is low, the patient is in shock, what we call hypovolemic shock. So when there is hypovolemia, in children you can look for skin turgor and other things, but in adults, one of the very important signs, if you can pick it up, would be a low JVP. So I think JVP slightly elevated will not grant you that, But then I want to ask a couple of things from you before they ask, the others ask. So there was no tachypnea, JVP was not elevated, liver spleen was not enlarged. Would you, in your impression, clinical impression after examination, say that the patient is not in failure, congestive heart failure right now, or a left ventricular failure, or a right ventricular failure? Call it
Yes, sir.
congestive.
Patient is currently not in failure.
Okay.
It's progressing towards
Okay.
failure, but is currently not in a
Cardiac,
position of failure.
you have not got any signs. So would we go back to Devabrata and ask him whether the history needs to be rectified, that his symptoms of breathlessness and palpitations have resolved over the past 4 days, 2 days, 2 weeks, or something like that? Have they resolved?
Sorry,
You
sir,
know,
I
it's
didn't
very
get the
important,
question.
because if patient is symptomatic, then we should find something. Right, let's concentrate on your findings. You said tapping apex, which is out, and loud S1, and opening snap, and a mid-diastolic rumble, loud P2, which was normally after a normal split, you should say that earlier, and liver spleen again not congested, which will also be against a feature of congestive heart failure. So I think what you should say, the patient is not, when you say RSD and whatever you are saying MS, patient not in congestive cardiac failure, number one. Number two, patient in atrial fibrillation. You did not tell us the pulse deficit. So when you auscultate and when you feel the pulse and you calculate the pulse deficit in atrial fibrillation, you will find that's a huge deficit. So patient not in failure, patient in atrial fibrillation, and loud P2, does it suggest that there is pulmonary arterial hypertension?
Yes, sir.
So you should put that in your clinical findings. Okay.
Okay.
Now, why is the apex shifted outwards? Why is the apex be
Sir,
shifted outwards?
basically, apex is formed majorly by left ventricle and a part of interventricular septum. So it is shifted outwards because of ventricular dilatation.
So left ventricle is not even getting blood. Why would it get dilated? There is metastenosis that prevents the blood from getting into the left ventricle. Okay, so shifting to the outwards would imply that there is right ventricular hypertrophy, which occurs in patients with, when there is parasternal heave in patients with MS. Okay, right. Let's go to the third part. Act 3 of our play. Let us go to the Act 3. Yes. Yes, please.
Hello. Good morning, sir.
Yeah.
I'm audible.
Yes, very much.
Okay, sir. Sir, I will be presenting with the investigation part. First will be the lab studies, CBC, complete blood count, which we will do just to rule out the anemia or infection as a potential cause of heart failure. Urine analysis, it may reveal proteinuria, which is associated with cardiovascular disease. Serum electrolyte levels may be abnormal owing to the causes such as fluid retention or renal dysfunction in severe heart failure. Fasting lipid levels to evaluate dyslipidemia.
So there is one question that has come from Matiz Hossein. If pedal edema is present, can we simply call it heart failure? After ruling out nephrotic syndrome and other causes of edema. Now, how do you rule out, based on lab studies, other causes of pedal edema? This is a
Sir,
question
here
that,
pedal edema.
yeah.
Sir,
Yeah.
here pedal edema is not present.
No, the question was, if pedal edema were present, can we call it heart failure? Query. After ruling out nephrotic syndrome and other causes of edema, so I'm taking it from there and asking you what lab test will help us in ruling out other causes of pedal edema. And as you said, you also said there was no pedal edema. Anisha wants to know, is it possible that patient has edema and there are no signs of ventricular failure, which is the other way around, or patient has got fluid retention and there is no pedal edema?
Sir, we can differentiate on the basis of physical examination, but I don't know, sir, about the lab studies, any specific test.
So once the pedal edema sets in, that means the retention of fluid has occurred to the extent of 5 to 8 liters at least. So remember, pedal edema does not come up soon after the fluid has been retained. And that is why measuring the body weight is a better indicator of fluid retention rather than looking for pedal edema. And that's why when you treat these patients with rheumatic heart disease or congestive cardiac failure of any origin, you tell them you take your weight daily morning. That would be a good indicator rather than pedal edema. And the pedal edema also has to be looked on over a bony prominence, and you press it for 30 seconds and then you look for the bit. Very often there are lacunae there. In case there is pedal edema, that does not always translate into congestive failure because there could be other causes. The causes that would come for pedal edema would be same like what you talk of edema. One, it could be part of venous arca, or one, it could be a local pathology. Venous arca would imply it could be renal pathology where there is puffiness and there is pedal edema because of protein getting lost. And a urine test here for proteinuria, which you have listed at number 2, would be very helpful. And also the measurement of serum albumin globulin would be useful. A similar thing could occur in a liver disease, chronic liver disease, where the albumin formation goes down and low hyperalbuminemia presents as pedal edema as a part of Nasarka. The difference between renal and hepatic would be when you measure the albumin and globulin. When you measure the albumin and globulin, the ratio, AG ratio, will be reversed in liver disorders, but both albumin and globulin would be low in patients with renal pathologies. We used to see these toxins called dropsy, where also pedal edema could be present, and then there are some other allergic conditions that could show it. Pedal edema could also be present in the limbs from the venous occlusion. So you have these venous occlusion or the leakages that can give rise to it, or you have these lymphatic obstructions, filariasis and others, where the pedal edema is there. So pedal edema has too many causes, and it does not always mean RBF. It also, the corollary also here is that there may be pedal edema and no other signs of right ventricular failure because pedal edema may not be made. The point comes, if you stretch it further, the point comes, is it possible that a person is in right ventricular failure and there is no pedal edema? Sorry, there are no signs of right ventricular failure and there is pedal edema. So remember, the right ventricular failure, the impact of the back pressure is felt first by the liver. And that is why you get the pulsatile hepatomegaly as a first sign even before the pedal edema. So if there is pedal edema, no hepatomegaly, no other signs of right failure, look for some other causes you can see clinically or on the laboratory investigations. Why is there left ventricular hypertrophy in case of MS? We never said it. In fact, Chetan said it, and I think he also backed it. We backed out because Left ventricle is not under any pressure. LFT, KFT, serum albumin, KFT, CLBC, CBC. Okay, these tests. Please proceed further to your
Yes, sir.
list of
Yes, sir.
investigations.
We will also do the blood urea nitrogen and serum creatinine, which may indicate the decreased renal flow. We will do the fasting blood glucose because the elevated levels can indicate increased risk of heart failure. We will do the cardiac enzymes assay, that is the troponin I, CKMB, and myoglobin. Just to see any prior MI, we will do the ABG levels for the evaluation of hypoxemia, hypercapnia, respiratory acidosis, dilutional hyponatremia. We will do the LFT, in which we will do the liver enzymes. Abnormal LFT indicates the hepatic congestion and volume overload. We will do the thyroid function test. As hyperthyroidism can cause atrial fibrillation and hypothyroidism can cause heart failure. So to rule out any thyroid pathology, we will do the TFT.
Okay.
Next slide. Imaging studies. First, we will do the chest radiography. That is. Yes,
One
sir.
second. Any comments
Yes,
on these tests? There is a whole list of tests that he has put out, and very often we see it in the exams also coming out like this. But we don't do all these many tests, even though he has given a good coverage because the differential list is so big. In this case, you know, from the questions that we got from your colleagues, is whether the patient is in failure or not. Because history suggests there is failure and findings suggest there is no failure. So is there a test that you can do for failure?
Yes, sir. I have mentioned ahead that by doing the echo
BNP?
and yes, sir. I have mentioned in the ahead slide, sir. BN and terminal pro BNP and BNP assay.
Yes. So that assay should be useful, and now the assay of your imaging studies, the chest X-ray would be useful. Please go ahead.
Chest X-ray, cardiomegaly with a cardiothoracic ratio greater than 50%. Early CHF may indicate, may manifest as cephalization of pulmonary vessels, generally reflecting a pulmonary capillary wedge pressure of 12 to 18 mm of Hg. As interstitial fluid accumulates, more advanced CHF may be demonstrated by curly B lines, where the pulmonary capillary wedge pressure is 18 to 25 mm of Hg.
Okay.
Pulmonary edema is observed as perihilar infiltrates, often in the classic batwing pattern, reflecting a pulmonary capillary wedge pressure of more than 25 mm of Hg.
Okay.
In stage 1 CHF, basically the redistribution of the fluid happens, which is manifested as the blue arrows, which are showing the cephalization of the pulmonary vessels, mainly in the upper lobe, and the red arrow is showing the increased width of the vascular pedicel, which is from the pulmonary trunk to the aortic arch, which is shown by the red arrows.
So this what
Yes,
you're
sir.
showing as the blue are the pulmonary venous hypertension. The vessels are pulmonary
Yes, sir.
veins that become in failure. Okay, carry on.
Yes, sir. Yes. So next.
Okay, next.
Stage 2 CHF, mainly the interstitial edema happens, which is manifested as curly A lines, which extend radially from the hilum to the upper lobes, representing thickening of the interlobular septa that contain lymphatic connections. Next slide.
Okay.
Curly B lines are also seen in the lower part of the lungs, which are short horizontal lines situated perpendicularly to the pleural surface at the lung base. They represent edema of the interlobar septa. Next slide. Third finding is the peribronchial cuffing, which is the thickening of the bronchial walls, and also perihilar gaze is seen, which is the loss of definition of these walls, that is the bronchial walls, as you can see in the X-ray. The thickening of the horizontal fissure can also be appreciated because of the fluid accumulation in the major or minor fissure beyond the pencil point thickness, which it can normally attain. In stage 3 CHF, the alveolar edema happens, which is manifested with the perihilar consolidations and air bronchograms. That is the bat-wing pulmonary opacities, which you can see in the corresponding X-ray, which is represented by the yellow arrows. The pleural fluid is also can be seen, which is represented by the blue arrows, and the prominent azygous vein and increased width of the vascular pedicel, which can be appreciated by the red arrow, and the enlarged cardiac silhouette, which is represented by the red arrowheads. Then we will do the electrocardiogram. A routine 12-lead ECG is done. Yes, sir.
One second. There is one more X-ray view that you can do, because somebody was raising that issue of left ventricular hypertrophy and right ventricular hypertrophy. So if you want to see the right ventricular hypertrophy, you can take a lateral view also.
Yes, sir.
So if you take a lateral view, then in the substernal area, just below the sternum, is the right ventricular that shows up in a lateral view. And if it is hypertrophy, then you'll see more than 1/3, normally less than 1/3 of the lower part of the sternum, less than 1/3 of the sternum is touching the artist that much part. If it is more, then that will give you an idea. Okay, please carry on with the ECG.
Sir. A routine 12-lead ECG is done. The major importance is to assess the cardiac rhythm and determine the presence of determine the presence of any ventricular hypertrophy or a prior MI. Also used to determine the QRS width and QRS changes. Next slide.
Yeah.
The left atrial enlargement is the first and the earliest finding, which is seen in our case, which is seen on ECG on 2 leads, that is lead 2 and lead V1. In lead 2, we will see the bifid P wave, which is also called as camel hump wave or P mitral. And in the lead V1, we can see that the terminal negative portion is increased, that is more than 40 ms duration. It is seen because of the left atrial enlargement. Next slide. After the left atrial enlargement, laterally it can progress to the right ventricular hypertrophy, which is manifested on the ECG. As we can see in the lead 1, the R wave amplitude or the height is increased more than 7 mm. Next slide. Then we will do the 2-dimensional echocardiogram, or that is the Doppler. It provides a semi-quantitative assessment of left ventricular size and function, as well as the presence or absence of valvular and or regional wall motion abnormalities, which can indicate a prior MI. We will also assess the Doppler echo is used to assess the left ventricular ejection fraction, left ventricular size, left atrial size, wall thickness of the atria and ventricle, wall function, and in this case, the area of the mitral valve is less than 1.5 centimeters square, which indicate the severe mitral stenosis. Next slide. We can also check out the ejection fraction by doing the Doppler echo. Ejection fraction is calculated as the stroke volume divided by end diastolic volume. Normal ejection fraction is more than or equal to 50%, which indicate that the systolic function is adequate. But in our case, the ejection fraction is significantly depressed, that is less than 40%, as left ventricular contractility is depressed. Next. Okay. Exercise. Sir, exercise testing is not usually done in cases of severe heart failure, but we can do it for assessing the need for a cardiac transplantation in patients with advanced heart failure. Sir, in it, a peak oxygen uptake of less than 14 ml per kg per minute is associated with poor prognosis. and this peak oxygen uptake is shown to have better survival when transplanted than when treated medically. Next slide. The biomarkers which we will do are the BNP, that is B-type natriuretic peptide, and anti-pro-BNP, that is N-terminal pro-BNP. Both are released from the failing heart and are increased in CHF. These are useful for establishing disease severity and prognosis in chronic heart failure, and also useful in achieving optimal dosing of medical therapy in clinically euvolemic patients. My diagnosis: acquired valvular heart disease, moderate to severe MS, secondary to RHD, causing pulmonary hypertension with atrial fibrillation, with no evidence of infective endocarditis or active rheumatic disease. Thank you, sir.
Okay, and you should write no
Yes,
congestive heart failure.
Okay,
Okay, good. So we'll go to the last part. Before you start the last part, somebody has asked me about that point we were making on right ventricular hypertrophy on the lateral X-ray. When you take a lateral view of the chest X-ray, let us say this is the sternum that you are seeing. Okay, from top neck area to the diaphragm area. So let us say this you divide it into three areas. So top third, bottom third, and middle third of the sternum that you can see at the edge of the X-ray. When you look at the cardiac silhouette is just on substernal. But if you look at it, the lower part of it is touching some part of sternum. Now, the interior part of the shadow, cardiac silhouette that you see in the lateral vein is comprising of the right ventricle. If the right ventricle is enlarged, then the touching is not only in the lower third, but it crosses the lower third and may go into the middle third also. So that would speak of right ventricular enlarged. Okay, let's go to the treatment. Right. So I hope that answers somebody wants this to be repeated. Okay, please carry on with the treatment.
Good morning, sir. Am I audible?
Yes.
Sir, I will be starting with the treatment. Sir, before going to slides, in 2 minutes, I will be giving the overview. Sir, first, if the patient presents with decomposition, he will be having pulmonary edema, decreased contraction, and in this case, he was having atrial fibrillation. Sir, so for pulmonary edema, we will keep the patient in proper position, then give oxygen therapy. A diuretic will be given, and venodilators like nitroglycerin or BNP analogs like mesaridine can be given. For decreased contraction, we can give dobutamine. If the patient is having oliguria, we can give dopamine, and other newer agents like levosimendan can be given. For atrial fibrillation, we can do rate control and rhythm control. For rate control, we can give beta blockers, CCBs, etc. And for rhythm control, there are class 3 Bogan-Williams like amidron, ibudilide, sotalol. Sir, now after stabilizing the patient, pardon.
Yeah.
After stabilizing the patient, now the patient is having MS. For this, we can do balloon mitral valvolectomy or mitral valve replacement, and for this we will see further. Sir, then if we don't treat it now, the neuroendocrine compensation will start. So due to increased sympathetic activity and RAS activation, there will be remodeling. So to control that, we will give drugs. And sir, if even that fails, then we can use VADs or cardiac transplant. So now I will be going to the slides.
Okay.
Chetan, first slide. The drugs given in the slide on the right side are what we give in compensation, decompensation. Diuretics and vasodilators and the drugs which increase the contraction have been mentioned here. And on the left hand side, these are drugs which we give to prevent the remodeling. Next slide, please. Chetan, next slide. Again, in acute decomposition, these are the drugs. There are vasodilators, then there are diuretics, and there are inotropic agents. In vasodilators, there are nitroglycerin, nitroprusside, and seretide. Seretide is the BNP analog. Then in diuretics, there is loop diuretic Lasix and thiazide diuretic bumetanide. Then in inotropic agents, we can give dubutanine, milrinone, levosmandin, etc. Next. So this slide shows the pathophysiology of cardiac remodeling, which is due to neuroendocrine activation. So in sympathetic system will be activated and RAS system will be activated. The angiotensin 2 will lead to increased aldosterone, which will lead to cardiac remodeling, and also through ATO1 receptors. So this flowchart shows the drugs which had already been shown acting at various levels to decrease the remodeling. Next slide, please. So now the drugs which prevent the remodeling, here they are ACE inhibitors, which decrease the remodeling and improve the survival. It can be combined with spironolactone. Then there can be given beta blockers, which reduce the mortality by giving all these through all these mechanisms, especially carvedilol, metoprolol, and bisoprolol. In here, I have been talking about mortality again and again because this drug we commonly give is digoxin. It has been known to provide symptomatic relief, but it does not prevent mortality. Next. So digoxin acts by sodium potassium ATPase inhibition, which lead to increased intracellular calcium, which will increase the inotropic effect. Next. Back. So in this graph, we can see the Frank-Starling law. The uppermost curve is normal with the increased preload, which is shown in the x-axis, and y-axis there is increased stroke volume. As the normal is shown in the uppermost curve. In heart failure, the lowermost curve shows that the stroke volume is decreased, which will lead to increased back pressure and pulmonary edema. What digoxin does is it increases the curve to the left, so the pulmonary edema can be prevented and it provides symptomatic relief. Next. So as I already mentioned, it provides only symptomatic relief but has no role in preventing the mortality. Next. So this drug has a very narrow therapeutic range, and its toxicity occurs it fits more than 2 nanogram per ml, and it can show various types of arrhythmias. Next. So then these arrhythmias can be treated by giving potassium infusion, which blocks the action of digoxin. Then for ventricular arrhythmias, lidocaine can be given, and atropine and beta blockers can also be given. There is antibody specific to digoxin, digibind, which can also prevent toxicity. Next. Now, sir, after we can monitor the treatment as told by Dipinder. We had already taken the BNPs. Now we can measure how the BNPs vary with the treatment to monitor the treatment. Next. So then this is the mnemonic to remember all the drugs that have been told. We have already discussed the pharmacological approach. The non-pharmacological will be told in next few slides. Next slide. Sir, I had talked about balloon mitral valvotomy and mitral valve replacement. Sir, in this slide, we can see the various criteria after which we can do mitral valvotomy. So, firstly, according to the clinical symptoms, if the NYH is 3-4, means the patient is having symptoms at less than normal activity or he is at rest, as told by Devbrat. Then the signs of heart failure were told by Chetan. Then Dipinder's echo showed the mitral valve area, which is normally 4 to 6, and here it is less than 1.5, which is severe. So then left ventricular ejection fraction as told by color Doppler, which can be more than 50, which is preserved ejection fraction, or less than 40, which is reduced. And reduced is a means indication to go for valvotomy. Then pregnancy. As I said, pregnancy has specifically been included because it is very common comorbidity complicating pregnancy, and in Clark's classification of cardiovascular mortality in pregnancy, it has been in class 2. Then said first line is balloon mitral valvotomy. If there are any contraindications, like there is at echo we find there is a thrombus in left atria, then we will anticoagulation, then do valvotomy. Or if there is MR or calcified valve, then we can do mitral valve replacement. Next. Next. Sir, then there is non-pharmacological approach. Sir, we are here to treat the patient, not just the condition. We have to look at overall picture. So we will educate the patient as well as the family. We will tell about the disease, the prognosis, the symptoms which may need hospitalization, when to bring back the patient, and we have to rehabilitate the patient, tertiary prevention. Then, sir, in the previous slide, I had told that we can do balloon mitral valve, whatever mitral valve replacement. So these are actually very expensive procedures, and according to Google search, in Delhi it costs about 70,000 for balloon valvotomy, and MVR costs more than 1.5 lakh. So, and our patient's income is only shown to be 7,000 per month. He can't afford that, so we must advise him to go to Ayushman Bharat and paneled hospitals so that he can get treated, which will offer free of cost. Next. Yes, sir. And then there is, in the pathophysiology, we had seen the remodeling, which was due to salt water retention. So we can advise salt restriction and fluid restriction. And sir, fatty acid supplements have been shown to reduce the BNP in the patient. Next. So then exercise has also been shown to decrease the mortality in the patients. Next. So when all the modalities fail, then we can use ventricular assist devices, then or cardiac transplant. Until then, we can do ventricular assist devices. There are various generations of pads. It may be left ventricular assist device, right or bi-level pad, or even total artificial heart, or it can be heart made 2 or 3. So various devices are available in case the ventricles stop functioning. That's all from my side, sir.
Okay, so that is a very extensive coverage on the treatment of congestive heart failure and all the drugs and the toxicities and their management, and going on to ventricular assisted devices and a possible cardiac transplant, and in fact covering the pregnancy also, none of which, according to your predecessor, was present. I mean, one is even doubtful whether there are signs of congestive heart failure, and of course there is no question of pregnancy. So in this young man, that's very good coverage, very extensive coverage, more theoretical. But remember, when you're covering it in a young man, don't talk of so much of pregnancy unless they ask you.
Yes,
I have 2 questions from you. You have done
yes, sir.
very extensive. One is the role of antimicrobials in a patient like this.
Yes, sir. So the patient is developing pulmonary edema, which may predispose to infection. So prophylactic antibiotics can be given. And sir,
He has been put on penicillin long time back, and is advised to take it very regularly.
yes,
So I think you must keep in mind that the role of antibiotics for the prevention of acute rheumatic fever, which could lead to worsening, or role of antibiotics to prevent in certain circumstances, because you talk of surgeries, including cardiac surgeries. So role of antibiotics in preventive infective endocarditis. So there are 2 different concepts. One is prevention of rheumatic fever with anti-streptococcal drugs, and second is prevention of acute infective endocarditis, acute endocarditis within conditions.
yes,
And the second thing you should have covered in greater detail, like what you did for the failures, is the use of anticoagulants in a patient who has got atrial fibrillation. This patient
yes,
has got atrial fibrillation, and if you don't use it, those arrhythmias will embolize into
ambulance.
the systemic circulation. And every month we see one person with rheumatic heart disease, rheumatoid heart disease, where either anticoagulation has not been prescribed, or if it has been prescribed, it has not been emphasized, and the person is not taking. And these young fellows come with stroke, which makes double whammy of the patient's primary disease, which is bad, and having a stroke on top of a rheumatic heart disease is even worse. So I think those things you have to keep in mind. We have been talking quite a lot, and I don't think it is good for us. If there are any questions, you can ask, and we will not take any more case otherwise. Okay, so if there are any questions, do ask us. Otherwise, we'll close the session. Anyone? Anyone? Any questions, comments, or anything? Okay, if there are none, then I would request you to. How did I put it? Then I would request you to have a nice day further down. Thank you so much for attending this session and contributing to it with your comments and queries and everything. Okay? Right.
Thank you, sir.
Now,
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you,
So
sir.
let
Thank
me-
you.
Thank you. Have a nice day. Let me switch it off. Switch it off. So, where is so? Will you put it off or I'll put it off? Let me take out the.